with which we can actually find out the entire brain network. So we can now, we now have the capability of analyzing the whole brain network.
Okay.
And from there, we can both structural as well as the functional. And from this functional thing, applying some advanced mathematics and so on, we can extract quite a lot of quantitative metrics, which we can then put into the machine learning environment, or even not in the machine learning environment, but just looking at them, we can do quite a lot of decision making. Obviously, one problem is the artifact in EEG.
Okay.
But
less artifact when the patient's asleep.
Yeah, exactly. That's much better.
And that's been one of the issues, is that if you give the patient a neuromuscular blocker, then you see a reduction in our current depth monitoring devices.
Yeah.
And so it's well known that these devices were initially designed on patients without neuromuscular blocker, but we tend to use them on patients where we do give neuromuscular blocking.
Yeah.
So it's fascinating. But if you ever want to trial it to look at depth of anesthesia or to look at consciousness, we could definitely chat and set something up.
Absolutely. I'm very much keen to do that at this moment, because we have the tools already available. And as I just tried to mention, that whatever work we have done, the main core of this is the methods that we developed, which can be applied in lots of different contexts, whenever or wherever you want to really understand the signal and try to relate it with a state. That is where we come in. So if you have some data, I would be very much interested to have some, because then we can actually, I can give it to some of my students, and we can just generate some preliminary results, and from there we can probably go for some proposals or something like that. That's pretty much straightforward.
Yeah, I mean, it would be very easy, I'm sure, to get ethics to test it on some patients.
Yeah, I don't know. Do you know David Allen?
David Allen, no.
Neurophysiologist.
Okay.
So David and I work closely, and in fact, this time I gave this project of consciousness to 2 students who are working with me at this moment. They're doing their 3rd-year project just to explore what happens there. But yeah, I mean, as long as we have data, then we can explore lots of things, even unconventional. That's what I want to say.
Susan's just come in. She's another institute.
Hi, Susan.
Interesting.
Sorry to interrupt. I think I joined slightly late. So can you just summarize what that was referring to that you were talking about? Because I've made some notes, but I didn't catch the beginning of it. The moderation associate, so I'm just making some notes from this session.
So we're just talking about depth of anesthesia monitoring and what the sort of opportunities might be available from Kushik's work.
Okay, great.
Yeah,
that was the bit, the main bit.
Yeah.
Because what we try to do is that we just from the whole use of physiological signal point of view. The interesting thing is that our traditional way of thinking is that I will just look at the signal and see if there is something, right? So I just give you one example, that when we started to work with the ECG signal particularly, we were trying to predict some sort of impending episode. Okay, the initial thing was it's not possible just from ECG.
Okay.
And then we tried to think in terms of heart as a dynamic system rather than a biological system. What are the properties of a dynamic system? And try to see the signals coming out from there, from that perspective. Yes, if you look at the TRESS, you will not probably see too many things apart from these wave intervals, blah, blah, blah. But when we transform that into time frequency domain or in phase domain, these are probably some kind of words for technical things. But these are different techniques of analyzing the signals. Or if we try to break down the signal adaptively into its fundamental components, then that yields loads of information that we can use for loads of different things. The same thing happened with EEG as well. So at what time, which part of the brains are synchronizing, at what time they are just flipping their synchronization, or how long they are maintaining synchronization. All these things could be now represented as a kind of, let's say, graph network. And once we have the graph network sort of thing, we can actually extract quite a lot of information from that, just from the dynamics of the graph and so on and so on. So we were able to apply this technique to actually show that you can classify between autistic and non-autistic children. And not only that, we can actually go into much deeper in terms of where in the autism spectrum the child actually lies, if we do it with the task-dependent thing. Then we try to apply it for anxiety, and yes, we can find out, because to be honest, the fundamental principle is the same, that how the communication in brain is going on. If I understand that, if I have a tool to understand that, or finding out that thing in kind of, let's say, quantitative way, then I can try to relate it with the state that I am looking for. So we can get the data and we can analyze the data and can see how it actually differs from the normal sleep condition or whatever, and then from there we can start to make the conclusions and so on. So that's absolutely fine. And as I say, the tools are there, but we don't have data.
Well, I mean, we do 50,000 operations here a year, so at Southampton Hospital, so there's definitely an opportunity for the data.
Well, that would be absolutely great, and certainly I'm very much interested. So if we can, what we can do is that we can start with some of the data to see what we can get out from there, and then take it forward. And if we get some good result, then probably we can go for some sort of research proposal or something like that. I think that's possible.
Okay. Well, I will let other people step in and ask questions,
Sure.
plug their ideas, but I will send you an email and we can chat more. Thank you.
Thank you. So Suzanne, what's your interest actually?
So I'm an anaesthetist as well. So I have kind of, would probably very much overlap. I haven't had particularly any involvement in this kind of field, but this kind of research or anything in that way. So I was here just out of interest, and it is curious. I mean, the thing that stood out, in addition to the depths of anesthesia monitoring, the other thing that stood out to me in what you've just said is that you were looking at anxiety. And I thought, I wonder if you could do something like your pre-op obs or your pre-assessment, when they come in a few days ahead of the surgery, whether you kind of do your pulse, your blood pressure, and actually get an anxiety measure, because there probably is things that would come out of that in terms of the way you either provide them information or adapt your techniques. And things like blood pressure, like we know that the blood pressure goes up if people are anxious, and a lot of the time we blame high blood pressure on them being anxious, or vice versa, we underestimate it, and then through the anaesthetic we're trying to keep the blood pressure at a certain level because we think that's their normal, but actually it isn't, because they were just a bit anxious. And that was the only thing where I thought, that would be something
that is where maybe I can just throw in another piece of work that we are doing at this moment. I have given this work to 2 of my undergrad project students, and they're producing fantastic results. That is related to heart-brain interaction. So basically, simultaneous recording of ECG and EEG, and then trying to see how synchronizing at different bands of EEG. So just this morning, one of my students sent me the result for that, where we found out that the T wave of ECG is very, very highly correlated to delta band of EEG signal. And then there are some other pockets as well, which are giving tremendous synchronization things. So the point that you mentioned, like blood pressure, and then anxiety and the depth of anesthesia and so on, they are actually quite related, that I can find out. Particularly because the different waves of ECG, the way they are getting synchronized with different types of different frequency bands, and as you know that the different frequency bands has different type of implications, then that actually gives us quite a lot of interesting opportunity to look at heart-brain monitoring together to predict quite a lot of states and also to measure quite a lot of states. So I cannot claim too much into that at this moment unless I go through the entire result. But the thing is that we have already started working on that, just with this idea that maybe at some point I can just check the heart condition, which is easier to measure because I can just put in a bipolar wearable ECG. Wearable ECG is much easier to use than wearable EEG. And whether we can get some sort of idea of what is happening in the brain from monitoring the condition of heart, if we have enough data to monitor them in parallel. So we can build up a model where finally I can just put in the heart data, and probably that's going to give us quite a lot of information about what's happening in the brain. So we are actually doing that sort of analysis at this moment.
And is this the sort of thing, so I mean, I was listening to the talks earlier where they were talking about, so James Badger was talking about the kind of pre-assessment and decision making that they were doing. Is that something that you're involved with?
Well, not in that project, but the thing is that, as we all know, that activities in Southampton are extremely fragmented.
Yeah.
And nobody knows what other people are doing, or that's why probably we have this event. I have done parallel thing as part of large European project. And so we have developed entire monitoring system for cardiovascular diseases that have been trialed in our cardiology and in Policlinico Umberto Primo in Rome.
Yeah.
We have also done the similar kind of thing for stroke rehabilitation. So monitoring home-based stroke rehabilitation system, that how the subjects are doing and so on and so on. So we have already done all the things, and we have all the necessary tools. We have developed all the necessary tools over the last 10 plus years. So they are here to use. Yeah. That's my actual message that I can give, that we have developed all these things, and we can do their modification according to the need of application. But yes, I mean, when I heard James Badger's talk, then I was just wondering why we did not know about this initiative earlier.
Yeah. Cool. Thank you very much. I'll let someone else join.
Thanks. So I see quite a lot of participants already. So if anybody wants to talk about anything particularly, I can obviously explain things. I can explain what type of works we are doing and what the implications are, where we can apply those things. Those who were listening to the previous discussions, I mean, the discussions we were having at this room, of course, you got some idea of what we are doing at this moment. But if you're interested in particular topic or something like that, of course, please just feel free to ask, and then we can discuss it. Well, in short, what we are offering is a holistic work that involves data, signal processing, and machine learning together. So that's where we have done lots of work, and we have lots of tools already available. So obviously that can be applied from cardiology to lung diseases and also the brain signal processing. And so essentially the message that I'm just trying to give is that we have those things here. And if anybody is interested for the clinical purpose to apply any of these expertise, then probably we are your person.
You've already talked about applying it to anxiety monitoring, synchronization of the heart and the brain. What other domains have you looked at? Are there any other clinical areas that have been looked at?
Well, one of the areas we looked at was, for example, remote monitoring of movements. So that was very important for stroke rehabilitation system development. What happened is that how do a clinician know or a physiotherapist know that the subject is actually following the regular routine of exercise? Now, we cannot put a camera in the room because that is intrusion to the personal space. So what we can do is that we can put some sensors. And remember that this is a mobile environment. Therefore, what happens is that all the data that we capture by the sensors are corrupted by extreme artifacts. So the challenge is now separate out artifacts, read the data, analyze the data to find out what movement the person has done. So let's say the clinician has suggested that you need to do reach and retrieve movement 6 times in a session. Okay. Another point here is that how do I know that the patient is complying with that? That is where our work comes in. What we do is that from the sensor, we pick up the data. These are small wearable sensors. We pick up the data, we analyze the thing, and we say that this person has done it 6 times, and each time the movement quality was like this. So we had to come out with different types of quantitative measures which we can apply to characterize the quality of the movement of the person. That is fed back automatically to the physiotherapist, and the physiotherapist now knows that, okay, the person has complied with the exercise I have asked him or her to do, but it seems that the movement quality is staying really bad, so I need to change the exercise or something like that. So this we have actually developed under another European project, and it's a big system, but we played the central part in it, and it is possible to apply that sort of system very easily, or it is easy to build up such a system straight away here. So that is another aspect. So heart, brain, and this is the other thing. And the other part that I am looking at this moment is neurostimulation. Because what I believe is that, well, when I looked at all the literatures for neurostimulation, I found that they are quite contradictory. And it seems that some of the processes work, some of the processes don't work. The question is why they are like that. It seems that there is no solid theoretical foundation on choosing the parameters. So for example, if I say that I'm going to give transcranial direct current stimulation, I keep on giving some current, maybe let's say 25 minutes, and then leave the person and just observe. The question is, who said that 30 minutes or 25 minutes is fine? where is the evidence? Where is the evidence that direct current will actually work? And the other thing that I found actually missing is that, is it just the stimulation of an area of the brain? Or is it the signal propagation from one stimulated area of the brain to the other stimulated area to do certain type of task? Because if I just imagine that we have two different islands, and in one island some activities happen, but there is no way to communicate that activity to the other island. So is there a connection between them? No. From the information point of view, there is no connection. And therefore they will not work. Just putting the current to activate one area is not going to work unless we actually look into the holistic thing. And that's where some new type of thing comes in, which is basically modeling the tracks between two different areas and understand how the signal actually propagates from one point to the other point. Because if we do that, then we can use the structural MRI to understand how the signal is propagating and how we can make sure that the signal is propagating in a diseased population. So for example, dementia, we know that there is a blockage between two different areas. Question is how we can bypass that blockage to keep the people going and so on. So these are the different areas that we are concentrating at this moment. So yeah, those are kind of things. Yeah.
What numbers of patients are required to produce a model that's sort of reliable?
Well, to be honest, that depends upon the problem I am tackling. First of all, if you want to create a generalized model, it has to be huge number of samples that I need. And that is of the order of something like, let's say, at least 500, 1000. Then I can say that we will be able to do a model which is probably 70% correct. So we really need huge amount of data because there is no magic wand. There is no magic wand to say that, okay, I have two data and then immediately apply something and get a model. It doesn't work like that. So for example, even for the movement tracking, for the stroke patients, if you look at that, maybe you will be doing reach and retrieve task and I will be doing the reach and retrieve task. But if you look at the raw electronic data, they are markedly different. They're simply different. So the question here is that, am I going to make a generalized model or am I going to make a person-specific model? Now, this is where the interesting thing comes because biologically, we have quite a lot of variations in different people. And therefore, what happens is that one's characteristics may not be same as other people's characteristics. So we need to think in terms of hierarchical structure. The structure is at the top may be generalized model, but then it has to be trimmed down to the individual level. So in order to make this generalized model, we need huge amount of data. Ideally, I could just say 50,000 data, which is probably not possible. And therefore, basically, poor men have no choice. So we will be just happy with something like 100 or 500 data to begin with for any type of operation, any type of, let's say, tool building and so on. This is particularly important when we go for the brains or developing the neuroprosthetics or the heart related thing, particularly the chronic heart disease sort of stuffs, heart failure and arrhythmic attack sort of stuffs.
And how do you go about validating the model?
Again, that is where the question about data comes into the picture. So And the validation thing actually differs depending upon whether I am going for a person-specific model or a generalized model. So there are different ways of verifying. One way is just, if I have 50,000 data, let's say, I just use 25,000 data and do not touch the rest of the 25,000 data. And once the model is built based on this first 25,000 data, then we test it with respect to the unseen 25,000 data. And we need to check, depending upon what we are trying to do, is sensitivity, specificity, ROC, etc., etc. Now, maybe with 25,000 data, I find that the model is probably 70% accurate. Then I am going to increase the data from this unknown or unseen 25,000. Maybe I take 5,000 more data and try to build up the model. But this time, every time, the point is that I think this is something that we need to understand. Machine learning is not a magic. Machine learning is basically an algorithm. And therefore, what happens is that if I give garbage data, machine learning will give me garbage result. So it is extremely important to choose the right data to cover all the possible scenario that we are thinking of applying the system in. Therefore, if I am considering that I have to actually do some kind of, let's say, arrhythmia prediction, let's say atrial fibrillation, then I need, and under whatever condition, so under an anxiety attack or under some other things, maybe temperature is too high or whatever, then I have to actually use those particular data to build up the right, build the right model. So that's what I would say, that we have to be very much careful about our choice of data, because the quality of the data will dictate the model, and obviously that will limit the applicability of the system in reality. So kind of these are the kind of things that I would say. And I mean, there is a general perception that, okay, I give you data and you find out something from there. And that sometimes creates a problem, because there is a gap in language between the engineers and clinicians. So probably when seeing the data, I think one problem from the engineer side is that engineers are not completely specific all the time to exactly what data they want. And the doctors think that, okay, we can just give any data that comes out from this, some sort of related clinical action. And that is where the problem is. So, for example, if I want to go for epilepsy prediction, okay, we have done quite a lot of work on epileptic seizure prediction. Now, I can pick up the EEG, I can do the analysis and so on, and I can find out several features. But in most clinical cases, what happens is that we get data maybe just 1 minute before the actual seizure happens. Now, there is no point in looking into this data to find out some features for doing prediction. Because what I want to do is to predict whether there will be an epileptic seizure in the next 30 minutes or so. But I just don't have that long data. If I have a data with, let's say, 1 minute or 30 seconds before the epileptic seizure occurs, and I completely understand that why the data is like that, because nobody is doing continuous monitoring to these patients. Probably we don't have the capability to do that in terms of wearable devices or whatever. It's only happening when somebody is having an epileptic seizure and we just see the data. And so there is this. So in that case, if I want to predict epilepsy, let's say 30 minutes before it happens, and I get the data with only 1 minute length before the actual seizure happens, that's useless. So that is where, this is just an example where the engineers and clinicians need to discuss and accordingly find the appropriate data to get a tangible result out of the whole thing. So this is one very important point that I would say to consider.
We have about 5 more minutes before we're going to return to the main meeting.
Yeah. I think probably there is no more question, and then I don't know how much, probably 3 minutes left.
Are there any more questions? If not, we can maybe return to the main meeting.
Probably not. Then probably we can just go back to the main meeting, I guess.
Thank you very much for
sharing.
sharing.
Thank you very much. Thank you. Thank you. Thank you for moderating.